This video demonstrates suture button congruent arc Latarjet procedure. Preoperative design. 3D CT scan was performed to outline the bilateral shoulder joints preoperatively. According to the PICO technique, the proportion of the glenoid bone loss and the size and shape of the glenoid deflect arc could be measured. The glenoid deflect decline angle and the cricoid osteotomy line was measured and confirmed in each case according to the CT image. Patient position and the surgical portals. The patient was placed in a beach chair position. The body markers of the shoulder joint and the surgical approaches were marked. The graft heaviest skin incision, which is the anterior portal, anterior lateral portal, and the posterior portal were made to complete the whole procedure. Cricoid osteotomy and the suture button configuration. A 25 mm skin incision was made. Packed manner and part of the C ligament fibers were separated. The cricoid was measured under the direct vision according to the preoperative design. An orthotic saw was used to cut the cricoid down. Separate the pedicle of the conjoint tendon downward using the index finger to 5 to 6 cm long. When performing the cricoid medial side decollocation, the angle between the medial side of the cricoid and the bottom of the cricoid should be equal to or greater than the decline angle of the glenoid defect. A 2 mm central tunnel and a 1.5 mm side tunnel were made. 3 high-stress sutures were put through the antebottom and the central tunnel of the cricoid for fixation. Another anti-rotation suture was pulled through the side of the hole of the antebottom and either side of the side tunnel respectively. Packed manner reconstruction would be performed if the detached muscle was able to suture to the cricoid with low tension. Arthroscopic evaluation, anti-rotation anchor positioning, and a rotator interval debridgement. The diagnostic arthroscopy was performed for glenoid bone loss, heel sacs, and other lesions. The projection point of the upper edge of the subscapularis on the anterior glenoid was marked as one of the glenoid bone tunnel reference and the place of the anti-rotation anchor insertion. The rotator interval was removed until the anterior cricoid bone block was visualized. Glenoid preparation, bone tunnel positioning, and draining. Viewing from AL portal, the glenoid deficiency bone bed was refreshed. The bare area of the glenoid or the center of the PFC was measured and confirmed. A microfracture awl was used to mark predetermined outlet of the tunnel. A custom-made locator was inserted along with switch stick, and a 2.5 mm guide pin was drilled. A PDS was passed through the glenoid tunnel as guide suture. Mini subscapularis split window. The subscapularis was split from posterior to anterior at the level of lower 1/3. The medial border of the split was the glenoid surface. The capsule and a part of the muscle was split. A switch stick or grasper was passed through the split from anterior to posterior, lateral to the glenoid surface. A PDS suture was passed through the split and guide sutures on the bone block, passing through the window and pulled out from AL portal for later use. Then the anterior side of the window and the axial nerve were observed, which in this case the nerve is far from the window. Cricoid graft transfer and fixation. Viewing from the AL portal, a suture retriever was inserted, pulling the sutures in bone block posteriorly. Adjust the direction of the tip of the triangular bone block and let it pass through the split into the glenoid humeral joint by pulling the anti-rotation sutures posteriorly. By using the Procet guide PDS suture, pull the fixation sutures of the cricoid into the glenoid bone tunnel. Then fixation sutures and anti-rotation sutures were pulled in turn to adjust the graft position, so it was flush to the glenoid surface. The anti-rotation and the traction sutures were fixed by push-lock anchors in the corresponding position. Then the congruent arc was restored. Thank you for your attention.